Our topic for today is vascular orbital and lacrimal gland tumors. We'll be discussing about the clinical features of vascular benign tumors like orbital varix, hemangiomas, and lymphangiomas, their appropriate investigation and management options, and then we'll discuss about some lacrimal gland tumors. First, we'll come to the orbital varices. Basically, vascular lesions are broadly divided into either high flow or low flow. Any lesion having some arterial component in it will be described as a high flow lesion, like for example an arteriovenous fistula. Secondly, if a lesion has a capillary or venous component, then it is described as a low flow lesion, like for example a lymphangioma or hemangioma. So varices are basically plexuses of distensible low flow vein like thin walled vessels. They are basically hematomas. Can anyone tell what is a hematoma? Yes, it's a disorganized, overgrown tissue, but present at its original position. Orbital varices are usually associated with lid and conjunctival varices. They may be congenital or acquired as a result of a localized high flow lesion or trauma. As described earlier, these are low flow lesions because they have venous component. They are mostly unilateral and present in the upper nasal portion of the orbit. Non-pulsatile proptosis without bruit is present because of the low flow. We will not find bruits. Since they are in communication with the systemic circulation oftenly, so they will enlarge with Valsalva. With Valsalva, the venous pressure increases, so these varices will enlarge. And due to this phenomena, there will be positional and inducible proptosis. When the venous pressure will increase, the proptosis will become more prominent. Venous pressure can be increased by making a head down position or with Valsalva or exerting pressure on the jugular veins. Apart from these findings, usually the rest of the examination is normal. There is no engorgement of conjunctival veins or arteries, and the IOP is also symmetrical in both eyes. These are the images of varices. In the first picture, you can see the eyelid varices. Sorry, this shows for initial conjunctival varices. This row shows the absence of proptosis without Valsalva, and this picture shows slight proptosis happening and prominence happening with Valsalva. This picture I will discuss later on. This is again a picture of distended vessels like esophageal varices भी इसी तरह की नजर आती हैं. Complications. The first complication is acute orbital hemorrhage. Can anyone tell how it will present? There will be painful proptosis with visual loss. Secondly, the varices may become thrombosed. Thirdly, optic nerve compression may occur. Now we'll come to the investigations. Imaging techniques may show a lobulated mass with variable contrast enhancement with or without phleboliths. Phleboliths are basically stones or calcium accumulation. This is a picture of phleboliths. The image E shows the white spots which are actually stones occurring in the dilated vessels. Secondly, there may or may not be orbital expansion, and thirdly, there may or may not be orbital wall defects. The patient may be having some enophthalmic picture. The reason is that if the varices are long standing, they will be accompanied by atrophy of the orbital fat. So it will look like an enophthalmic patient, as you can see over here in the picture number F. The left area shows slight loss of this sulcus. The sulcus over here is is more prominent as compared to the right sulcus, so it shows that the eyeball is slightly sunken inwards. Coming to the treatment, small lesions usually don't require any treatment. Surgical excision is basically tough because these are highly vascular and friable, so there are high chances of bleeding. If we have to perform, we can go for embolization or CO2 based laser surgery. Indications of surgery are basically the complications. If there are complications happening like orbital hemorrhage, thrombosis, or optic nerve compression, then we have to perform excision. The second vascular lesion is lymphangioma. Again, since there is no arterial component, these are low flow lesions. This is also a hematomatous lesion. Basically, during embryological development, we know that in all cell lines, the most important cells are the stem cells or the pluripotent cells. So basically, some changes occur during that process, which leads to development of these abnormal vessels. They can occur in conjunctiva, eyelids, oropharynx, and paranasal sinuses. They may be classified as microcystic if are of below 2 centimeter size, macrocystic, or mixed micro and macrocystic. The most important thing is that they are incompressible and they do not distend with valsalva because they are not in communication with the systemic circulation. Another feature is that they may enlarge during upper respiratory tract infections, and we have mentioned earlier that they may also be present in the oropharynx. These are usually isolated from the systemic circulation, but sometimes intralesional bleed may occur, which may organize itself into the form of chocolate cysts, and they resolve with time. These lesions usually present in the early childhood. DDs में हमारे पास क्या आ सकता है? Hemangioma most important, क्योंकि इसकी look बिल्कुल वैसी होती है. They may be associated with intracranial malformations, vascular malformations. This is an anterior orbital lymphangioma with typical bluish discoloration, and you can see the globe is displaced infratemporally. Again, these are the pictures of lymphangiomas in a young child. As seen in the pictures, these are soft bluish masses in the upper nasal quadrant usually. Posterior lesions may cause proptosis. Anterior lesions usually don't cause proptosis like this. There is no proptosis over here. Spontaneous hemorrhage may occur in them, which may cause painful proptosis and orbital nerve compression. You can see in the above picture, the proptosis is evident, and you can see by the look that it looks like a hemorrhagic event. ये MRI का कौन सा कट है? कोरोनल है कि एक्सियल है? एक्सियल है. In the MRI scan, you can see proptosis and a filled lesion, retrobulbar lesion. सर ये T1 है, क्योंकि T1 में एक्यूट ब्लीड जो है वो ग्रे कलर का होता है. ट्रीटमेंट में प्रोग्नोसिस इज यूजुअली गुड विदाउट ट्रीटमेंट. इनकी भी ज़्यादातर हम एक्सीजन अवॉइड ही करते हैं क्योंकि these are not encapsulated and they may also lead to lot of bleeding if excised. However, if needed, we have to perform sometimes subtotal excisions repeatedly. CO2 laser may be used for the removal of chocolate cysts. The third lesion is infantile or capillary hemangioma. These are the commonest benign primary tumors of the orbit in children. It is again a hematoma. Usually it is present at birth or or manifests within first few weeks of life. The course is that it enlarges dramatically over the first 6 to 12 months, and then after first year it starts to involute, and mostly it goes away by 3 to 7 years of age. Some important associations are female gender, low birth weight, prematurity, and if maternal chorionic villus sampling has been done, it is seen as an association. The lesions may be either superficial, known as strawberry nevus, or dark or sorry, deep or preseptal, which appears dark blue or purple. These are non-pulsatile and no bruise is found. Large tumor may enlarge or turn deep blue during crying or staining. If the tumor is deep, it will lead to unilateral proptosis without any skin involvement. We have to check the eyelids and fornical conjunctiva for additional hemangioma always. You can see in this picture a small child with a capillary hemangioma. It is not very deep, but several months later you can see it has become prominent over here. We have not yet come to the treatment, but it is the first line of treatment is topical beta blockers, and you can see in the below row it has resolved a lot. The above picture shows the superficial type known as the strawberry hemangioma. It appears like the skin of a strawberry, and you can see in the below picture, as mentioned earlier, we have to check the fornical conjunctiva because we may find a hemangioma over there also. Again, it is a picture of strawberry nevus. Coming to the investigations, ultrasound may be helpful and may show internal reflectivity of medium level. CT and MRI are done. A soft tissue mass in anterior orbit or an extraconal mass with posterior expansions may be seen. Orbital cavity may be enlarged, but no bony erosion is usually found. You can see mouse. राइट क्लिक करें ऑप्शन आ गई माउस नजर नहीं आ रहा है Okay, this is an axial CT scan showing a homogeneous intraconal orbital soft tissue mass. ये मसल कोन है, ठीक है, और जो मैस है वो इसके अंदर है, मीन्स इट इज इंट्राकोनल और बिल्कुल एक प्लेन सी पिक्चर है, सो होमोजेनस इन अपीयरेंस. In complications, large and multiple lesions may be associated with visceral hemangiomas as well. This may lead to development of thrombocytopenia, especially if they bleed, or or after some time, high output heart failure as well. Indications for treatment include amblyopia, secondary to induced astigmatism, anisometropia, occlusion or ptosis, squint, cosmetic reasons, exposure keratopathy, and optic nerve compression if occurring. The first line of treatment are the beta blockers. Topical timolol is used usually for superficial lesions, or oral propranolol may be used for deeper lesions. Steroids may be used if the beta blockers fail. इसमें इंजेक्शन ट्रायमसिनोलोन आता है जिसकी डोज मेंशन्ड है. इंजेक्शन बीटामेथासोन में भी यूज. The injections may have usually they start to show results in 2 weeks, but they may be have to repeat it after every 2 months. Deep injection should be avoided. Can anyone tell why? Because it may lead to central retinal artery or some other vascular occlusion. Topical high potency steroids may be used, but they are usually slow in their effect. If we want quick action or if the orbital involvement is very large, then we may go for oral steroids. The third option is lasers, for especially for superficial skin lesions of size less than 2 mm. Interferon alpha 2a or alpha and vincristine may be used for steroid resistant cases. Local resection may be done usually for late and inactive stage, but if the sight or life is being threatened, then we have to go for early resection. The last vascular lesion is cavernous hemangioma. Usually occurs in middle-aged adults. Pregnancy may accelerate its growth. Commonest orbital tumor of adults. It behaves like a low-flow AV malformation, as mentioned before. Features may presents usually with axial proptosis but slowly. Disc edema, choroidal folds may be found. If the lesion is occurring at the orbital apex, it will definitely lead to orbital nerve compression, but proptosis may not be usually found, and extraocular movements may be impaired. This shows the histological picture. You can see there are endothelial lined vascular channels separated by fibrous tissue. This is right axial proptosis. Proptosis की कई causes होती हैं लेकिन and you can see in this CT a large well circumscribed homogeneous mass is present behind the globe. It is well circumscribed because it is usually encapsulated, as you can see in this picture. Whereas the previous lesions like varices and lymphangiomas, they were not encapsulated, इसलिए भी उनकी सर्जिकल एक्सीजन जो है उसको यूजुअली अवॉइड करते हैं. लेकिन इसका कैप्सूल बहुत अच्छा होता है जिसकी वजह से इसकी सर्जिकल एक्सीजन कर सकते हैं हम अर्ली भी. इन्वेस्टिगेशन में वी में गो फॉर अल्ट्रासाउंड, CT और MRI. As seen in the picture, a well circumscribed lesion is usually present within the cone. The arteriography or venography usually has no benefit because they are not very connected to the systemic circulation, these lesions, and they have an intact capsule. The first step in management is observation. Surgical excision is okay because of the intact and good capsule, but should be done if only symptomatic. Now we'll come to the lacrimal gland tumors. The first most important tumor is the pleomorphic adenoma. The commonest epithelial tumor of the lacrimal gland, commonest epithelial benign tumor of the lacrimal gland is pleomorphic adenoma. Usually presents by the age of 40 and 50, and men have been found to have greater involvement. There is progressive painless inframedial displacement of the globe with axial proptosis. Because the gland is lateral, so the globe will be displaced inframedially. A firm lobular mass may be found near the supralateral orbital rim. Imaging techniques reveal enlargement or expansion of the lacrimal sac fossa, and a well circumscribed but slightly nodular mass may be found. The mass may be nodular. Coming to the histopathology, because often some questions have the histology in their stems, so histopathology is important. There may be varied cellular structure. Benign tumor है तो benign epithelial cells नजर आएंगे. Stroma में spindle cells with occasional cartilaginous, mucinous or even osteoid element may be found. An important feature is pseudocapsule. Not a true capsule is there, but a pseudocapsule is an important feature. And as you can see, a male, the globe is slightly displaced inframedially the right globe, which is not very prominent. This is an axial CT scan showing a mass in the supratemporal orbit, EMS. Coronal CT showing uh, mass with globe displacement, and this is the specimen with a pseudocapsule. Management includes complete removal with inclusion of the pseudocapsule and surrounding margin of the orbital tissue. However, we mostly avoid taking direct biopsy before the excision because देखा गया कि 32% cases में recurrence हो गई थी. Second important tumor is adenoid cystic carcinoma of lacrimal gland, the most common malignant epithelial tumor of the lacrimal gland. There is perineural invasion and bone destruction which leads to pain, and whereas the pleomorphic adenoma is painless. Secondly, this tumor has a rapid course and it develops within 1 year, whereas pleomorphic adenoma has a slow course. This tumor lacks a capsule, so it may infiltrate posteriorly into the deeper orbit. It is a malignant tumor, but deceptively, on histology, the cells may be benign appearing, growing in tubules, nest, or Swiss cheese pattern. Basaloid morphology is associated with a poorer prognosis as compared to the cribriform morphology. Since this tumor lacks a capsule, so it may infiltrate posteriorly and there may be perineural invasion as well. Malignant mixed tumor of the lacrimal gland. Histologically, it is similar to pleomorphic adenoma, but it may include areas of malignant change. Usually, uh, adenocarcinomatous changes may be found. If the pleomorphic adenoma is very long standing or it has recurred, then malignant element may start to develop in it. अगर कोई प्लियोमॉर्फिक एडिनोमा है और उसकी ग्रोथ बहुत ज़्यादा रैपिडली हो रही है तो हमने उसमें malignant change सस्पेक्ट करना है. The basic management of all lacrimal gland malignant tumors is biopsy, the first step. Secondly, we have to perform primarily orbital exentration or radical orbitectomy followed by radiotherapy. Neoadjuvant intra-arterial chemotherapy followed by exentration is another option, and radiation therapy may be done only. This tumor may also lead to death because of its ability to infiltrate posteriorly into the orbit, ultimately entering into the cranial cavity, and systemic metastasis may also lead to complications. Thank you. Okay. The commonest cause of unilateral proptosis in a 45-year-old man: cavernous hemangioma, idiopathic orbital inflammatory disease, lymphoproliferative disease, glioma और thyroid. थायराइड है इसका आंसर. एडल्ट में यूनिलैटरल प्रोप्टोसिस हो या बायलैटरल हो, एक्सियल हो या नॉन एक्सियल हो, मोस्ट कॉमन कॉज नंबर 1 पे थायराइड आई डिजीज ही है. An MRI is done for investigation of headaches in an otherwise fit and healthy 52-year-old female. A circumscribed intraconal 20 mm round lesion is noted in the orbit. It is homogeneous, high signal on T2, which is most likely diagnosis. Cavernous hemangioma, metastasis, pleomorphic, solitary fibrous tumor और thyroid eye disease. ठीक है, इसका कवर्नेस ही आंसर है. वजह यह है कि इंट्राकोनल है, ठीक है. सेकेंडली होमोजेनस है और एज भी फीमेल प्रिपोंडेंस होती है इसमें और एज भी कैवर्नस हेमेंजियोमा वाली है. ब्रेस्ट मेटास्टेसिस इसलिए नहीं हो सकता क्योंकि मेट्स जो है यूजुअली बहुत लेट प्रेजेंट करते हैं और उनकी वेरिएबल फीचर्स होते हैं. होमोजेनस भी हो सकता है, हेट्रोजेनस भी हो सकता है. प्लियोमॉर्फिक एडिनोमा इज एक्स्ट्राकोनल लीजन होती है प्लियोमॉर्फिक एडिनोमा, इंट्राकोनल नहीं हो सकती. Solitary fibrous tumor is a very rare tumor. It is not homogeneous, it is heterogeneous on imaging, while in scenario the lesion is homogeneous. Thyroid eye disease is not possible. A 40-year-old female presents with a 3-month history of painful swelling in the supratemporal quadrant of left orbit. She undergoes an incisional biopsy demonstrating glandular tubules with lumina, excess basement membrane and mucin, islands of anaplastic cells without squamous differentiation. Which is the most likely diagnosis? ठीक है, इसका यही आंसर है, क्योंकि मेलिग्नेंट ट्यूमर होता है और एनाप्लेजिया का जहाँ वर्ड आ गया तो वो मेलिग्नेंट चेंज को शो कर रहा है, और बहुत शॉर्ट हिस्ट्री है इसकी 3 मंथ्स की, और हमने पढ़ा था कि एडिनोइड सिस्टिक कार्सिनोमा विद इन 1 ईयर डेवलप हो जाता है। डेक्रियोएडिनाइटिस नहीं हो सकता, फैटी डीजनरेशन भी नहीं क्योंकि एनाप्लास्टिक सेल्स हैं, और एक प्लियोमॉर्फिक एडिनोमा तो बिल्कुल नहीं हो सकता क्योंकि अगेन एनाप्लास्टिक सेल्स है और बहुत शॉर्ट हिस्ट्री है। प्लियोमॉर्फिक एडिनोमा यूजुअली स्लोली ग्रो करता है, सार्कोइडोसिस भी नहीं। थैंक यू।
Topic well, but I would suggest you to always check on the internet also the latest information. You have studied from the book, and the knowledge in the book is about 5 to 10 years old. The latest information you will get from internet, PubMed. Now the international classification for orbital vascular diseases divides the vascular diseases into 2 categories. What are the 2 categories? All the problems are called anomalies, vascular anomalies, and the 2 subtypes are vascular malformations and what is the other? Tumors. So these are 2 categories of vascular abnormalities in the orbit. Either these are tumors or these are vascular malformations. So now we do not use the word of varix, cavernous hemangioma, lymphangioma. Now all these are covered in vascular malformations. Vascular malformations can be divided into lymphatic, arteriovenous, or venous or arterial depending upon the flow. No flow, low flow, high flow. I have published an article in the Pakistan Journal of Ophthalmology last month, so you can read that in the latest issue, PGO. The vascular malformations, I saw about 20 cases of vascular malformations in this hospital in the last 5 years, so I have published all those in the article. So you have to search for the latest nomenclature. Right. So varices, now varices, we don't use the word of varix. These are vascular malformations, arteriovenous. So we have to check for pulsations, thrill and bruit. Valsalva maneuver, whether these precipitate with the head down position or you close the nose and blow so that the venous pressure increases. Now, capillary hemangioma, we treat when there is fear of amblyopia, when there is danger of exposure keratopathy. Now, for superficial capillary hemangioma, what is the treatment? तो बीटा ब्लॉकर किस नाम से आता है? कौन सा बीटा ब्लॉकर है? So any drop or gel can be used, which is timolol or nylol gel. You can put a drop on the skin and spread it with the finger twice a day. So this is for superficial capillary hemangiomas. For deeper capillary hemangiomas, which is the preferred treatment? Oral propranolol. So what is the complications of oral propranolol? One, or hypoglycemia. See, the pulse rate, heart rate, and the glucose level should be monitored. So it is better to advise the oral propranolol treatment under child specialist, neonatologist, or if it is an infant, then the child specialist, because they can do ECG, they can do the glucose test, and they can monitor the how. You see, there are problems. Patient does not take feed, so whether to give the medicine or not. So parents have to be taught all these points: when to omit the dose and when to increase the dose. So it should be responsibility of child specialist. You can monitor the ocular findings, but for the general treatment, it's better to hand over it to the child specialist, the oral propranolol treatment. Okay, so about lymphangioma. So what are the different options we have? These are vessels, not encapsulated and causing proptosis. The sclerosing agent injection is a good option. And any example of sclerosing agent which we can inject intralesionally? Bleomycin. So we have injected bleomycin here in this hospital in a few cases of lymphangioma. The response was very good. So this is one option. Uh, for what are the other treatment options for the vascular malformations where you have tough vessels? You see how you differentiate the vascular malformation from the tumors. The tumors will keep on growing, increasing in size, but this capillary hemangioma or varices, they do not grow. They have a limited growth and then they stop growing. So these are not tumors. These are vascular malformations. So what are other options, for example, for varices or embolization? Okay. So who does the embolization? Interventional radiologist. So what are the different materials which are used for uh, this clogging or embolization of the vessel? One is cyanoacrylate glue, another is onyx. So these are frequently, there is a long list of different materials which can be used by the interventional radiologist to embolize the vessel so that the rest of the vascular tree sort of squeezes, tumor regresses in size. Then we have coils which can be sort of implanted. So from where the radiologist gets in the vascular system, रेडियल और फेमरल. सो यहाँ से वो जाते हैं कैथीटर के जरिए वहाँ पहुँच के. तो इट इज़ नाइस टू हैव अ व्यू. जनरल हॉस्पिटल में लॉट ऑफ सच प्रोसीजर्स आर डन बाय इंटरवेंशनल रेडियोलॉजिस्ट. तो कभी आप रेडियोलॉजी डिपार्टमेंट में जाएं, जाके देखें हाउ इट इज़ बीइंग डन. Okay, so coming to the cavernous hemangioma. Now, cavernous hemangioma, we now call it vascular malformation of cavernous type, not cavernous hemangioma. So, these are well capsulated, very easy to take out. So there is a sort of potential space around the mass, so the excision is easy and would really pop out very comfortably. So, so when would you like to have CT? Orbital lesion. When would you like to have CT and when would you like to have MRI? If there is calcification, what would you prefer? CT. So that's why we used to have CT for the retinoblastoma previously. See, but now they say that it gives lot of radiation, so the preferred mode is MRI. The guideline have changed. Previously, because of the calcification, because the CT picks calcification easily. Secondly, whenever the bone is, you suspect the bone is affected, CT is a better choice. Like in lacrimal gland tumor, you want to see whether the bone erosion has taken place or not. In pleomorphic adenoma, there will be indentation, smooth, there will not be bone erosion. But in carcinoma of the lacrimal gland, there will be erosion of the bone. So in malignant tumors, there is bone nibbling. You can see the defects in the bone. So CT is a better option. And for the soft tissue swelling, MRI is a better. Okay, so you want to remove a lacrimal gland tumor. Previously, what was the technique used for it? How you approach a lacrimal gland tumor? From medial orbit, upper orbit, lateral orbit. So you do a lateral orbitotomy. And what do you do in lateral orbitotomy? You take out a piece of zygomatic bone, make an incision in the zygomatic lateral margin, lateral border of the orbit, up and down, and take the piece out, remove the tumor, and put the piece back with the hole. I've done lateral orbitotomies with the help of this drill. You make small holes so that you can skewer it in position with the help of Prolene suture. But now many people prefer to do lateral to remove the tumor without lateral orbitotomy, just by pushing the eyeball medially. So you can do it both ways, but you should know the term of lateral orbitotomy to remove the zygomatic bone. Okay, so the lacrimal gland tumor will push the eyeball in which direction? Inframediate. So if there is dystopia and the eyeball is pushed down and medially, so you should automatically suspect lacrimal gland mass. You see, the location is very important. If there is right iliac fossa pain, what do you suspect? Number one, appendicitis. Number two, maybe ovarian cyst or something like that. But whenever there is a mass on the medial canthus, so what would you suspect? Lacunar. Diagnosis. So the location is important to diagnose. So first, you should always uh, think of the structure which is present there. Okay. Any comment? Any question?